Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome to the deep dive. Today, we're tackling a real clinical challenge, almost a masquerade act, really. Two conditions that can look incredibly similar when a patient first presents.
That's right.
But they demand vastly different approaches from us. We're talking about bowel obstruction versus intestinal pseudo-obstruction.
Yes, two very different beasts hiding under similar symptoms.
And this deep dive is specifically for you, our listeners, the doctors and surgeons making these calls every day.
Yeah.
Because getting this distinction right is, well, it's fundamental to good patient outcomes.
Absolutely fundamental.
And just a quick but really crucial note before we jump in. Everything we discuss here today is for your reference, for educational insight. Always make sure you're adhering to your local guidelines and established clinical protocols in actual practice.
That's vital to remember. And what's so fascinating and frankly challenging is how these two conditions, despite that shared symptom, list the pain, the distension, the vomiting, they actually represent fundamentally different physiological problems going on inside the bowel.
Yeah.
And getting that diagnosis spot on isn't just about picking the right treatment plan. It's about preventing some really potentially grave consequences for the patient.
Okay.
So our mission today is really to shine a light on those core differences, from the mechanism right through to management, and really stress why making that distinction is so critical at the bedside.
Okay, let's unpack that. Similar presentation, vastly different underlying issue. So, starting right at the beginning, the core distinction. We're talking physical barrier versus a functional problem, right?
Mm-hmm.
Can you lay that foundational difference out for us?
Precisely. Yeah, at its heart, a true bowel obstruction means there's a physical, a mechanical blockage somewhere in the intestine. Something is literally blocking the road, preventing the normal passage of contents.
Like a roadblock?
Exactly. It could be partial or it could be complete. And while it can happen anywhere, about 80% of the time it's in the small intestine, the other 20% or so in the large bowel. Now, contrast that with intestinal pseudo-obstruction. Here, you get all the signs, all the symptoms of a blockage, the distension, the pain, the vomiting. But when you actually look, often with imaging, there's no physical barrier to find.
Nothing actually blocking the way.
No. Instead, what you have is a severe problem with intestinal motility. It's a functional failure, a breakdown in the neuromuscular system within the bowel wall itself. The gut just isn't contracting and moving things along properly.
So one is like a traffic jam caused by a crash. The other is like the traffic lights are all out system-wide. The why is completely different.
That's a great analogy, yes. And that difference is the absolute cornerstone for everything that follows: diagnosis, treatment, prognosis.
Which immediately tells us why getting it wrong could be so dangerous.
Yeah.
So given these different fundamental problems, what are the typical culprits? What actually causes each of these conditions?
Right. Let's get into the etiology. It's quite different for each. Let's start with the true mechanical obstructions, the actual physical roadblocks.
Okay, what are the usual suspects there? Where do these physical barriers come from?
Well, for true mechanical obstruction, in the U.S. at least, the number one risk factor, especially for small bowel obstruction, is abdominal adhesion.
Scar tissue, right, from previous surgeries.
Exactly, that internal scar tissue that can form after someone's had abdominal or pelvic surgery. It's a really common issue. Then you have hernias, where a piece of intestine gets trapped, incarcerated in a weak spot in the abdominal wall. Malignant tumors are another major cause, particularly things like colon cancer, which is actually a leading cause of large bowel obstructions.
Okay.
We also see obstructions caused by strictures, sort of narrowings from inflammatory bowel disease, especially Crohn's disease. And then there are more dramatic mechanical causes like volvulus, where the intestine actually twists on itself.
Cutting off its own blood supply sometimes, too.
Potentially, yes, that's a major risk with volvulus. And particularly in young children, usually under 3, you think about intussusception. That's where one segment of the bowel telescopes into the segment next to it.
Okay, so that's a pretty clear list of physical, often structural problems: adhesions, hernias, tumors, strictures, twists. Now, for pseudo-obstruction, you said it's the system itself failing. That sounds more complex. What drives that motility failure?
It is generally a more complex picture, yes. Pseudo-obstruction isn't about that physical block. It's about the bowel losing its ability to coordinate movement. We usually categorize it as either acute, and the classic example there is Ogilvie syndrome, which specifically affects the colon, or chronic, which we often call CIPO, chronic intestinal pseudo-obstruction.
Okay.
The underlying reasons often involve the autonomic nervous system, an imbalance between the sympathetic and parasympathetic signals controlling the gut. And this dysfunction can be triggered by a whole range of things: major surgery, significant trauma, severe infections or illness, even certain medications.
What kind of medications are we talking about?
Oh, definitely things like opioids, which are notorious for slowing gut motility. Also, anticholinergics, some calcium channel blockers.
Yes.
It's a list clinicians really need to keep in mind.
Right.
Beyond that, we also see pseudo-obstruction linked to neuropathic disorders, problems with the nerves within the gut wall itself. Think Parkinson's, diabetes. Sometimes paraneoplastic syndromes, where the body's immune response to a cancer accidentally damages these nerves.
Wow.
And then there are myopathic disorders, where the problem lies within the smooth muscle of the intestine itself. Conditions like scleroderma or amyloidosis can affect the muscle function directly.
So it's a much broader range of potential causes: neurological, muscular, medication-induced, systemic illness triggers, compared to the more straightforward mechanical blockages.
Yeah.
The foundations are truly distinct. But, okay, let's bring it back to the patient walking in the door. For you, the clinician, faced with someone with abdominal pain, distension, vomiting, what clinical clues, what subtle differences in how they present might start nudging you towards one diagnosis over the other in those initial hours? Because the overlap sounds significant.
The overlap is the major diagnostic challenge initially. That classic quartet abdominal distension, which you see in maybe 80% of cases: nausea, vomiting, abdominal pain, and constipation or obstipation, that's common to both.
Though it's easy to see why it's confusing.
Very easy. But there are often subtle and sometimes not so subtle differences in the pattern and quality of those symptoms if you probe carefully.
Okay, what are those key distinguishing features we should be listening and looking for?
Well, for true bowel obstruction, the abdominal pain is often described as cramping, coming in waves like colic. There's often a buildup, a peak, and then it eases off temporarily before the next wave hits.
That crescendo-decrescendo pattern.
Exactly. And in a complete obstruction, the patient typically reports an absolute inability to pass gas or stool. Obstipation. That's a pretty hard stop.
Okay.
Listening to the abdomen auscultation can also provide clues. Early on, you might hear hyperactive, high-pitched bowel sounds, sometimes described as tinkling, as the gut tries really hard to push contents past the blockage. But later, as the bowel gets tired or ischemic, the sounds can become hypoactive or completely absent.
Right, the silence can be ominous.
It can be. And in very thin patients, you might even see waves of peristalsis moving across the abdominal wall. Symptom progression also tends to be relatively rapid in acute mechanical obstruction.
Okay, that's a distinct picture. How does pseudo-obstruction typically differ in its presentation?
With pseudo-obstruction, the onset is often more gradual, more insidious, although acute Ogilvie syndrome can present more abruptly, that's true.
Yeah.
A key feature can be the abdominal distension, which is often quite profound, sometimes seeming out of proportion to the amount of pain the patient reports.
Interesting. Massive distension, maybe less intense pain.
Relatively speaking, yes, that pattern can occur. Bowel sounds are usually different too. Instead of hyperactive early on, they tend to be hypoactive or absent throughout, reflecting that general failure of motility.
Makes sense. The system isn't trying to overcome a block, it's just sluggish or stopped.
Precisely. Symptoms in pseudo-obstruction, especially the chronic forms, can also fluctuate quite a bit over time. Periods of worsening distension and discomfort, alternating with periods of relative improvement. And critically, always look for an underlying trigger in the history recent surgery, a known medical condition like diabetes or Parkinson's, culprit medications. That context is vital.
That's incredibly helpful. Focusing not just that they have symptoms, but the character, the timing, the sounds, the context. But okay, history and physical give clues, but we need confirmation. This is where diagnostics come in, right? Imaging and labs must play a huge role.
Absolutely crucial. And imaging in particular is where we often get the definitive answer to distinguish the two. Radiological studies are really the backbone here.
Right. So let's talk imaging first. Abdominal x-rays, CT scans. What are we looking for? What are the key differentiating signs?
Okay, starting with plain abdominal x-rays. Both conditions can show dilated loops of bowel and air fluid levels. which can be confusing.
So X-ray alone might not be enough.
It might not be definitive, but it can give strong clues. The key differentiator to look for is a transition point. In true mechanical obstruction, you're hoping to see a point where dilated loops of bowel abruptly stop, and distal to that, the bowel is collapsed or decompressed. That marks the spot of the blockage.
The smoking gun.
Kind of, yes. In pseudo-obstruction, you typically see diffuse dilation, often involving the cecum and the proximal colon, maybe up to the splenic flexure, but without a clear transition point. It looks more like a widespread paralysis.
Got it. Diffuse dilation versus dilation up to a specific point.
Exactly. Now, CT scanning provides much more detail. It's really become the workhorse. CT can often directly identify the mechanical cause of a true obstruction. It can show you the adhesion band, the tumor, the hernia, the volvulus.
So it visualizes the actual block.
Yes. And just as importantly, if the CT shows dilated bowel but no mechanical cause, it strongly supports the diagnosis of pseudo-obstruction. CT is also vital for assessing complications, looking for signs of bowel wall thickening, pneumatosis, free air suggesting perforation, or poor contrast enhancement suggesting ischemia.
So CT is key for both diagnosis and assessing severity. What about contrast studies, like an enema?
Contrast enemas, usually with water-soluble contrast, can be very useful, especially if you suspect a large bowel obstruction. They can definitively rule out a mechanical blockage in the colon and rectum. And, as a side note, in children with intussusception, an air or contrast enema can sometimes be therapeutic, actually reducing the intussusception.
Okay, so imaging, especially CT, is really pivotal for seeing the anatomy and finding or excluding that mechanical cause. What role do lab tests play? Are there any blood tests that scream obstruction or pseudo-obstruction?
There's no single lab test that confirms either diagnosis on its own. But labs are absolutely crucial for assessing the patient's overall condition, the severity, fluid status, and importantly, looking for signs of complications.
What are the key labs to check?
You'll always get a complete blood count, CBC. A high white blood cell count, leukocytosis, can be a major red flag for complications like strangulation, ischemia, or perforation. We need to monitor serum electrolytes closely because vomiting and fluid shifts can cause significant imbalances, especially potassium.
Right, dehydration and electrolyte loss.
Definitely. And a very important one is serum lactate. An elevated lactate level is a serious warning sign for bowel ischemia tissue not getting enough oxygen, and that often necessitates urgent intervention.
Okay, lactate is a critical marker for ischemia.
Yes. We'd also typically check liver function tests, LFTs, and lipase, mainly to help rule out other causes of abdominal pain like pancreatitis or biliary issues. And in cases where you suspect chronic pseudo-obstruction, the workup might broaden to include tests for underlying autoimmune conditions, specific paraneoplastic antibodies like anti-Hu, or metabolic problems.
So labs paint the picture of the systemic impact and help flag complications, while imaging provides the anatomical diagnosis mechanical block versus motility failure.
Got it. So now you have your diagnosis, or at least a very strong suspicion. How do the hospital management strategies diverge? This must be where knowing the difference really impacts what you do next.
It absolutely dictates the next steps. But importantly, the initial stabilization is largely the same for both conditions. You have to stabilize the patient first, regardless of the underlying cause.
Makes sense. What does that initial stabilization involve? Standard measures. First, NPO status, nothing by mouth, to completely rest the bowel. Aggressive intravenous fluid resuscitation is critical to correct dehydration and electrolyte disturbances. We usually place a nasogastric NG tube on suction to decompress the stomach and proximal small bowel, which can relieve nausea and vomiting and reduce distension.
NG tube for decompression, fluids for resuscitation.
Right. And urinary catheterization helps us accurately monitor their urine output, which is a key indicator of fluid status and organ perfusion. Also crucial in this initial phase is addressing any potentially contributing factors, treating underlying infections or illnesses, and very importantly, stopping any medications that might be inhibiting motility, like opioids or anticholinergics.
Okay, so everyone gets stabilized, rested, hydrated, decompressed initially. Then the paths split. For true mechanical obstruction, what's the typical approach once they're stable? Surgery often comes to mind.
You're right, surgery is often central to managing true mechanical obstruction. However, it depends if it's partial or complete, and the suspected cause. For partial small bowel obstructions, especially those caused by adhesions, a trial of conservative management is often appropriate, continuing the NPO, IV fluids, NG decompression, and doing serial abdominal exams. A significant number of these will resolve without surgery.
So partial might resolve on its own sometimes.
Sometimes, yes. But complete obstructions generally require surgical intervention to physically relieve the blockage. The specific operation depends on the cause, lysis of adhesions, resection of a tumor or ischemic bowel segment, repairing a hernia, maybe creating a stoma.
Okay.
In specific situations like malignant large bowel obstruction, placing a self-expanding metal stent via colonoscopy can sometimes be used either as a bridge to elective surgery later or as a palliative measure in patients who aren't surgical candidates.
The stent can buy time or offer palliation.
Exactly, but the absolute critical point here is the need for emergency surgery if there are any signs suggesting strangulation or ischemia, things like worsening pain, fever, tachycardia, peritonitis on exam, rising white count, or metabolic acidosis, especially with that elevated lactate we mentioned. In those cases, you can't wait. Time is bowel, truly.
Got it. Urgent surgery if there's any hint of compromised bowel. Now, flip side, pseudo-obstruction. Once stable, the approach sounds completely different, much less surgically focused initially.
Completely different toolkit, generally. For pseudo-obstruction, the primary goals are decompression and trying to stimulate motility. Most cases of acute colonic pseudo-obstruction, Ogilvie syndrome, actually resolve within about 2 to 3 days with just that supportive care we talked about, NPO, fluids, NG tube, managing underlying issues.
So watchful waiting works often for Ogilvie's.
Often, yes. If the distension is severe, particularly if the cecal diameter is approaching that worrying 10-12 centimeter mark, or if it doesn't resolve with conservative measures, then we move to pharmacological therapy. The main drug used is neostigmine.
Neostigmine, okay. How does that work?
It's an acetylcholinesterase inhibitor, essentially boosting cholinergic activity, which stimulates colonic motility. It's given as a slow IV infusion, typically 2 milligrams over 3 to 5 minutes. It can be quite effective, leading to rapid decompression. But, and this is a big game, but it carries a significant risk of causing bradycardia, sometimes even a systole.
Whoa, okay. So not a drug to give lightly.
Absolutely not. It requires continuous cardiac monitoring during and immediately after administration, and you need atropine readily available at the bedside.
Got it. Careful monitoring is essential. What if neostigmine doesn't work or isn't safe for the patient?
If conservative measures in neostigmine fail, the next step is usually endoscopic decompression. A colonoscopy is performed to manually suction out air and fluid from the colon. This has a pretty good success rate, maybe 70–80%, but it also carries risks, mainly perforation, especially if the bowel wall is already thin and fragile.
Okay, colonoscopy is a decompression tool.
Right. Now, surgical intervention for pseudo-obstruction is really reserved for cases that fail all those medical and endoscopic approaches. Or, crucially, if complications like definite ischemia or perforation develop. Surgery isn't fixing a block here, it's usually dealing with the consequences of the failed motility. Procedures might include creating a cecostomy, a tube placed into the cecum for ongoing decompression, or sometimes require segmental colectomy with an ostomy if part of the colon is frankly necrotic.
The surgery is more of a last resort or for complications in pseudo-obstruction.
Generally, yes. And for chronic pseudo-obstruction, CIPO, the management is really about long-term strategies. Aggressive nutritional support, often requiring parenteral nutrition, EV feeding, managing symptoms with prokinetics or sometimes pain medications, and treating any identifiable underlying condition contributing to the motility disorder.
That really highlights the stark difference. Mechanical obstruction often needs surgery to fix the problem. Pseudo-obstruction management is mostly supportive, pharmacological, or endoscopic, with surgery playing a much more limited role, mainly for complications.
That's a key takeaway. The primary treatment modality is fundamentally different.
Understanding that difference is clearly paramount. What about the potential complications down the road and the overall prognosis? Why is timely intervention so critical for both?
Well, both conditions, if not diagnosed and managed effectively and promptly, can lead to very serious, potentially life-threatening complications. This really brings home why differentiating them matters so much.
What are the big dangers we need to watch out for? The worst-case scenarios.
The most feared immediate complications for both are bowel ischemia and perforation. As the bowel gets massively distended, pressure builds up, compromising blood flow to the bowel wall. Ischemia means tissue death, which can lead to perforation, a hole in the bowel. That risk increases dramatically when the cecum dilates beyond about 10 to 12 centimeters.
That cecal diameter is a critical warning sign then.
Absolutely. Once perforation occurs, or even with severe ischemia allowing bacteria to leak through the bowel wall, bacterial translocation, you can rapidly develop sepsis and peritonitis, which is a life-threatening systemic infection and inflammation of the abdominal cavity.
Okay, ischemia, perforation, sepsis, all very serious. What about longer-term issues?
Recurrent symptoms are a major issue. For patients with mechanical obstruction treated surgically, new adhesions can form, leading to future episodes of obstruction. It can become a recurring cycle for some patients. And for those with chronic pseudo-obstruction, the underlying motility disorder often persists, leading to ongoing relapsing symptoms.
The recurrence is common.
It can be. And particularly in chronic pseudo-obstruction, nutritional deficiencies are a huge concern. If the gut isn't moving properly, it can't absorb nutrients effectively, potentially leading to malnutrition and even intestinal failure requiring long-term IV nutrition.
That sounds incredibly challenging to manage long-term.
Hmm.
What about mortality? You mentioned grave consequences earlier.
The numbers really underscore the seriousness. For complicated pseudo-obstruction, meaning cases involving perforation or ischemia, mortality rates can be as high as 40%. Even uncomplicated cases, often occurring in already sick patients, might have a mortality rate around 15%. For mechanical bowel obstruction, mortality varies widely depending on the cause. For example, malignancy versus adhesions, whether there's strangulation, the patient's age and comorbidities, and crucially, how quickly appropriate treatment is initiated. But delayed treatment for strangulated bowel carries a very high mortality.
Those numbers are sobering. It really highlights that this isn't just an academic distinction. It's about timely, correct intervention to prevent potentially fatal outcomes. It truly is a race against time in many cases.
It absolutely is.
So pulling this all together, what's the key message for our listeners, for you in your daily practice? This deep dive really emphasizes that while bowel obstruction and pseudo-obstruction can look like twins on initial presentation, they are distinct entities needing very different, very precise management plans.
Exactly. And connecting this to the bigger picture, that accurate differentiation achieved through really careful history taking, a thorough physical exam, and the smart use of imaging, especially CT, it isn't just, clinically satisfying. It's absolutely essential for preventing those devastating complications like ischemia and perforation.
Right.
It also really reinforces the value of a multidisciplinary approach, doesn't it? Especially in complex or refractory cases involving gastroenterologists, surgeons, radiologists, critical care specialists, maybe nutritionists. Everyone collaborating is key.
Absolutely. Collaboration is vital. And for you, our listeners, you're the ones on the front lines making these tough calls, often under pressure. Think about those diagnostic tools. How can you really leverage that imaging information? Looking critically for that transition point or its absence. Using that CT scan not just to diagnose, but to assess for those subtle signs of complications. How can that guide your very next steps to get your patient onto the right pathway quickly?
That early, accurate pathway decision is everything.
It really is. Distinguishing that traffic jam from the power outage in the gut, doing it quickly, doing it accurately, that's often what makes the difference between a good outcome and a tragedy. Thank you so much for joining us on this really critical deep dive today. Keep learning, keep questioning, and keep making those informed, life-saving decisions at the bedside.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.